Good afternoon. It's always a pleasure for me to be able to speak at this conference. I'd like to thank the course directors for inviting me once again. I always feel at home with a group of general surgeons. They're kind of rare where I come from. So I have a couple disclosures to make here real quick that may not be in the program guide or the directory. One is I am not a pancreatic surgeon. I can tell you when it comes to necrotizing pancreatitis, I can't find one anywhere. So Dr. Schiller was introducing Dr. Persoff as a storm chaser. Storms chase me. This is one of them. I have a question to start off with here, and that is, in the management of pancreatitis with infected pancreatic necrosis, I have utilized minimally invasive necrosectomy, otherwise known as the step-up procedure. And answers would be yes on many occasions, yes once or a few times, or never. Just be advised, if you answer yes on many occasions, I'm going to have you come up and finish the talk for me. Okay, good. Very interesting. I see there are a few people that have done this more times than me. So anyway, let's go ahead and talk about pancreatic necrosis. And specifically, I'm going to discuss this in the vein of infected pancreatic necrosis, because that's usually where the operative indications come in. The first case that I want to present is a 48-year-old male who had a 10-year history of gallstones. He was obese. He had hypertension. He was admitted to an outside hospital with presumed gallstone pancreatitis, ended up undergoing an ERCP and sphincterotomy there. He was discharged after 10 days on a regular diet. This is a CAT scan from that institution. It's a little bit grainy, but you can see the peripancreatic edema and fluid, and just sort of concentrate on this one area, the central portion of the pancreas, that doesn't appear to light up with blood flow. So he was told it's okay to fly home to Phoenix. He did so and then came directly from the airport to our emergency department. He was tachycardic with abdominal pain and a white blood count of 35,000, admitted to the ICU, placed on antibiotics. He got better. His white count came down. An NJ tube was placed. He reached goal tube feeding and then was actually discharged another 10 days later on home nasojejunal tube feeding. We don't do that very often, but that's what happened here. This